So welcome. This is part of a series called Alumni in Action, and it features two Elon graduates today who are in the healthcare field and a faculty member who is instructing the next generation of public health leaders in our country. So with me today is Kristen Kotska, who's Elon class of 2011. And Kristen, did I say your last name right?
Yes, that's my married name. So my alumni degree says Feeney, but it's nice to be here today.
Okay, great. Class of 2011, and is the Associate Director of IQVIA, which is based in Massachusetts. And she has a master's degree in public health with a concentration in epidemiology, and is an expert in large-scale analytics and healthcare data science. So, Kristen, where did you do your MPH?
I went to Boston University, so I came home after being in North Carolina and joined the medical hub that is the Boston area.
I often, when I'm in Massachusetts, in that Boston area, I see a lot of Elon. See it on T-shirts and car stickers, and so I see a lot of Elon. We also have with us Patrick O'Malley, Elon class of 1996, who is an emergency physician in Newberry County Medical Center in South Carolina. He's been in practice for 12 years and has worked in small and large emergency departments and urgent cares. And Patrick, is Newberry, South Carolina, where Newberry College is?
It is.
Okay, so it's a beautiful campus. I was there last year there. So you really are right in the middle of rural and suburban healthcare issues right now. So I'll be interested in hearing what you have to say. And then lastly with us is Professor Katherine Johnson, who's an assistant professor of public health studies here at Elon. She is currently teaching a course called Preventing Pandemics. So that was already on the schedule even before the COVID-19 outbreak. And her research areas include global health, public health education and policy, and workforce development. So excited to hear from all of you today. So Kristen, why don't we just start off with you and talk a little bit about how you're professionally impacted and intersecting with what's happening around the world with the pandemic.
Absolutely. You know, as an epidemiologist, a few weeks ago, no one knew what the word epidemiologist was, and now everyone's an armchair epidemiologist. So it's kind of fun that I don't have to explain what I do for a job anymore. I'm very privileged. I work for a company that runs research engagements. We're a contract research organization, but I actually wear a hat that is my open science hat, and I'm part of a large global initiative called Odyssey, the Observational Health Data Sciences and Informatics Community. It's more than 200 organizations around the world that has 2.1 billion patients in a common data model. And we're running a lot of studies to understand what's happening to patients who are being treated, what are different subgroups experiencing. We're looking at different drug combinations, like everyone's favorite hydroxychloroquine. We just had a preprint on that, and that's under review at the Lancet right now. And we're looking at a number of other prediction models to help flatten the curve. So lots of active research. I've been living in this, what feels like every day in and out. And this headset is my command center for the whole world. So it's really great to be part of it. It's an exciting time to be an epidemiologist.
And so visible. You're right. We all have become armchair. I hadn't thought of that expression, but we're all reading these data charts and maps and trying to make sense of it. So have been especially appreciative of people who are trained in data science as it relates to health and public health. I just realized in 2011 we did not have a major in public health yet. And it is now the fastest growing major in the College of Arts and Sciences is our public health program. And so it's exciting to see an alum who navigated her way into that field. What was your undergraduate degree in?
I got a bachelor's of science in exercise science, and the minor existed. So I was kind of part of the inaugural group of folks. And Amanda Tapler was one of my research advisors. So she helped me get to the APHA conference in 2010. And, you know, there was some great support even when I was there. So I'm delighted to see the program grow.
Yeah, that's exciting. And I can tell it lit a fire, right? And then you pursued your MPH. So that's great. So what about you, Patrick? How are things in Newberry?
It's really kind of a surreal time because through social media, I'm connected with physicians, emergency physicians all across the country. and you're seeing what some of the hot spots in the larger metropolitan areas are. And then there are quite a few of us who still have not seen a single patient with COVID-19. So it's kind of a strange time. You know, we're preparing our hospitals and hospitals across the country who are kind of in the same boat as I am are preparing. You know, we're cutting down on the elective procedures. We're trying to plan and you know, wait for the inevitable. But it's, you know, as time goes on, we have been successful in flattening the curve, and you know, we're still hoping that we're not going to be seeing the surge, but still planning for that should it actually hit us. But still, as of yet, we've not seen any in my small town. I'm halfway between Greenville, South Carolina, and Columbia, South Carolina, where I work, and those larger areas in the state are definitely seeing it. And I think that the projected peak is within the next, you know, couple of weeks, but it still has not trickled into our community uh, to any significant degree. So I'm still just kind of, you know, we're watchful and waiting.
Well, you bring up a really important topic, and it's one that I know I had not fully realized until this pandemic, and that is the process of preparing to care,
Hmm.
and the cost of that. And our governor was just speaking to this a little bit ago when he was extending our shelter in place. One of the questions that came up was, well, what about elective surgeries where, you know, we've shut all of those down? And I hadn't realized, you know, I guess when you say elective surgery, people think about plastic surgery or some non-essential surgery, but these are actually quality of life issues for many people. Like the governor mentioned a hip replacement surgery that had been, you know, and obviously that's a painful condition. And so I just hadn't realized all of the trickle down impact. And then I read in South Carolina that, in fact, that MUSC laid off many of the medical professionals that perform those elective surgeries during this time, since they were not able to complete those.
Hmm. And I think that those are things that no one really thought was going to happen. You know, this has gone on now for what, 4 to 6 weeks in some places. And like you said, the trickle down effects, you know, hospitals have been buying up physician practices over the past 10 to 15 years, and hospitals are reliant on that elective surgery, the elective procedures, which generate so much revenue. And now, you know, so many of these service lines are being furloughed, they're being let go. You know, myself and my small town community emergency department, our volume is down by 40 to 50%. So we're seeing half of the volume that we typically would see. And that's happening all across the country. Emergency departments everywhere have just come to a screeching halt. And it raises a lot of interesting epidemiological questions as to why. But you know, when there's no revenue coming in, you're not able to pay for a lot of these other services that the hospital has to offer. And it's devastating small and large hospitals across the country and physician practices everywhere. People are really struggling.
Yeah, I know there is a lot of concern about rural communities right now and the viability of those
Right.
hospitals to be able to stay in business, and the essential, you know, they are the last, they are the only, you know, provider in those areas. So it just happened, Kristen, that you were teaching a class on pandemics, and so I am sure the students are having, and you as well, one of the deepest learning experiences you've profoundly probably had. So can you share a little bit about what's happening?
Sure, absolutely. As you've been saying, this was mere coincidence. This is one of our core capstone courses that rotates in and out of my schedule, and just happened to be slotted in this semester. And it's interesting because in past semesters that I've been teaching this course, normally I have to preface this discussion of pandemics with questions about other diseases and conditions and public health priorities that are more visible in people's lives. You know, so we talk about the emergence of electronic cigarettes. We talk about the impacts of obesity, in our society, these kinds of things. And, when I do polls at the beginning of class as far as, which of these issues matter most to you as an individual, just sitting in this chair right now, it's always those other kind of behavioral health or other sorts of issues that resonate most with students. And even this semester, we already had an emerging situation in China. We talked about, what's happening there. But when I asked students, which issues matter most to you, if I give you this menu of options, they would still, point to the opioid crisis. They would point to electronic cigarettes, things like that. And then quickly that changed before our very eyes. And so I think it's been both exciting and rewarding, but also, just like for the rest of us, frightening and unsettling to be able to talk about these strategies, these containment strategies, for example, in the textbook, right? And then see them play out in our own hometowns. So, students have been weighing in on discussion boards and in conversations about what do things look like in your small town or your large city, right? And how do those kind of experiences vary across our country and across the world? So, it's been both good and bad, I guess, to have the real live learning experience of the pandemic.
It's certainly elevating the work of public health, and a global, right? This interconnection that suddenly, I'm looking at world maps and I'm looking at all that data and trying to make sense of where the U.S. falls and all of that. Well, one of the things we keep hearing about, and I'm curious about your perspectives on this, and we'll just go around again, is about underlying conditions. That we keep hearing about the U.S. and the underlying conditions and the impact those underlying conditions are having on society in general. I've been hearing a lot about diabetes, and and that's another thing. I didn't have all that visibility and understanding about the significance of diabetes in our country, and then the higher risk that creates for not just this infection, but generally just the public health concern of that. So I'm just curious your thoughts, especially you mentioned running several studies in your work, Kristen.
Yeah, so, it's an interesting thing. We like to generalize and we like to think that everything is kind of the same, but there are many different shades that we're seeing. So the way that this pandemic has played out, we have a lot of data from Asia initially, but now the rest of the world is unfortunately catching up. And so some of the trends we saw in South Korea are actually not that similar to the US because totally different populations of people were exposed. You have more females in South Korea than in the US. And there's actually a lot of contradictory information right now where we're trying to understand and characterize the disease. So what are these people older? Are they younger? I'm on a manuscript that's out for review right now, and our network is suggesting that these are actually slightly healthier people who there are definitely some conditions that are coming to the top. We've looked at comparing to prior H1N1 season as well as 2014 to 2019 of the flu and try to understand, but they look a little healthier than some of our prior flu populations. And that makes it difficult because all of our a priori knowledge is built on some of these things. Now, that being said, we all know in epidemiology that your matrix of comorbidities only tends to make you a more complicated patient. And I'm sure Dr. O'Malley can speak to that too. But we have a lot of concern about figuring out the right subgroups. So one of the biggest things I'm working on is a huge protocol to look at all subgroups of interest and understand pediatric populations, pregnant populations, cancer populations, all sorts of cardiac complications, and really hone in and actually do analyses to understand those particular subgroups and adjust for things we already know are just part of being in that population that aren't necessarily because of the disease. And that's the fun of epidemiology. We have to really think critically about how we categorize these cohorts because there are so many factors at play.
Mm-hmm. And people are watching to find themselves in that data. Where am I in this age group? Where am I in this pre-existing condition? And so there are a lot of stories in data as well, right?
Exactly. And I have a couple of papers that we're working on that are actually individual patient level prediction models. So exactly the question you asked, how do I relate if I'm in this target population for developing this specific outcome? And just really, it's a probability. We don't know for sure because you yourself are still unique. But there are all different types of questions that we're asking, and it's important we put them in the right types of methods because they're not all the same type of thing that we would do to study it.
Very good. Well, Dr. O'Malley, what about you in the pre-existing, which I'm sure you see a lot of that in your work through in the emergency room?
In the emergency department, I mean, it's a daily struggle. You know, there was a study that just came out, I think this week, that the most common conditions that all of these patients that they have in common are hypertension, I think is number one, diabetes number two, and obesity. So those three things, I mean, in the emergency department, we just call that the triad. You know, everybody has hypertension, diabetes, and they're obese. So many of our patients, you know, that's what we see on a daily basis. So, you know, from a public health standpoint, I know that everybody has been trying to address those three things for decades, and I'm sure that we're making some headway, but until those three things exist, you know, I mean, our healthcare system is going to continue to be beleaguered by these chronic conditions that just contribute so much to morbidity and mortality. And then on top of that, you've got, you know, alcohol and tobacco, drug use, and you know, it's just the very, very common factors that lead to an overabundance of use and utilization of the healthcare system.
Yeah. Yeah. And in this time of shelter at home and in place, I know that there's been lots of talk about well-being and mental health. And, you know, I think a lot of people are concerned. It's not healthy to spend too much time by yourself, right? And I'm worried about, my mom's 82. I try to call her every day. And, but, you know, it also creates another layer of concern in addition to the physical elements of it.
I mean, the stress, anxiety, depression. I've heard reports of, you know, pretty significant increases in domestic violence, child abuse. You know, so there's a lot of other psychosocial impact that this is having that may not be, you know, as visible, but is definitely there, and we're going to be seeing the long-term impacts of that for a long time.
Is that in the literature about public health? And when you teach the pandemic class, is the underlying conditions, is that part of the literature, as well as these other consequences of the way in which we manage the infection rates?
Absolutely. I mean, you know, I think that around COVID-19 in particular, we have emerging literature. As we've been hearing, studies are being produced as we speak, and they're coming out day by day, because this is a new scenario and we don't know a lot of the answers. However, if we look at past diseases and conditions, even of pandemic proportion, you know, we were mentioning H1N1, we have past flu pandemics, and even other sorts of diseases that weren't necessarily officially defined as a pandemic, but that scared the world, right? Like Zika, for example, or when we suddenly had Ebola cases in our healthcare system in the United States. They're not at the same scale as far as the number of people that are impacted, but they definitely raise everyone's eyes way up, the same way that when we first started hearing about COVID, we get kind of attuned to. And so, you know, one of the things that we're most concerned about, or I should say I'm most concerned about, in both in the pandemics course, but I think I can kind of speak for my department and talk about public health generally, is the ways in which enduring inequities and kind of these kind of underlying challenges, societal challenges that extend beyond health, kind of systematically impact certain populations in certain ways. So who are these people that have diabetes, hypertension, obesity? Yes, it's all of us, we can say, but when we look at the proportionate impacts on certain types of populations, oftentimes they hit the same groups. And so, you know, one of the things we're concerned about in this class and also in public health generally is, what sort of systems and structures would it take to change some of that story, so that when people come to the emergency room with COVID, right, that's the immediate concern, and it's not also all these underlying conditions that they were structurally destined to get based on their profile in society. So it's a proportion, but you know, we know that there are these groups that are kind of systematically more impacted. And so I think, that kind of trend does play out in the research and in looking at past illnesses and diseases and who they affect most. And I think, it raises really tough questions for our society that we were asking ourselves before the pandemic, but I think we'll need to continue to ask ourselves about what are we going to do about these social inequities? How can we design a system that gives everybody a slightly more level playing field? And those are hard questions to answer.
Yeah, I do think, and this is my experience is that when you're in a crisis, you have visibility of things you didn't know before. And what I've always say, well, once you learn something, you can't unlearn it. And it does change your perspective and it changes your priorities. And suddenly the importance of things have become more visible to us, as well as the way that we're connected to each other, how our quality of life is all intertwined. So we're really feeling that all across the country, even if you don't have a case of COVID, because here in Alamance County, we haven't had a COVID case at Elon. Our county has had a little over 60 cases and no deaths, I think is what the data showed us today. But still, we are completely impacted by, even though a relatively suburban environment with low contagion being reported here. So I agree that there's a lot of visibility that's important right now, and hopefully the knowledge, and I'm confident it will, that this new knowledge, people are going to approach life differently and approach their priorities and understanding different,
Absolutely. It's galvanizing. I mean, if you can kind of harness this concern, right, to go into action instead of to just kind of retreat in fear, and I think that's kind of what we're all struggling with as individuals and also as a society, is just to kind of use this as the impetus we need to go forward.
And I also like the focus on that you brought up about unanswered questions, that we still have, Patrick, this unanswered question and about the impact of why this is happening in emergency rooms. And so really great. Well, thank you all for a great conversation today. And thank you for all that you're doing. I think we all also have an appreciation for how important it is to have a group of educated professionals working on this. So I think about that frequently, how grateful I am for all the work that's going on at many different levels to keep us all healthy during this. So thank you for that.